the panel that's coming up is an important one. It's going to discuss health equity and the social determinants of health. Handling that panel, no, I shouldn't say handling it. That's not right. Facilitating that panel will be the incomparable Mr. Gary Williams from another one of our partners, Jordan Health. So Gary, welcome to ABC Conference, and I will leave the panel with the amazing guests to you, sir. Take it away.
Perfect. Thank you so much for that lovely introduction. I'm honored to participate as a facilitator for this very important panel. For all, I will pose a series of questions to each and every one of you. By all means, take your time. And if I ask any follow-up questions, we'll, kind of take it from there. But I'm excited to have the opportunity to speak to each and every one of you. And for those who do not know me, I'm Gary Williams. I am the Chief Business Officer of Anthony Jordan Health Corporation. I've been with the organization for 50 days and counting, but who's counting, right? So I will start with Dr. Edith Williams, if you don't mind. Perfect. How are you, Dr. Williams?
I'm doing well. Great to see you, Gary.
Good. Good to see you as well. All right. Since becoming the director of the Center for Community Health, what are some of the objectives that have been implemented to improve health equity?
Thank you for that question. And please remind me how much time I have to respond so I don't.
Minutes.
You said how many?
7 minutes.
Oh, okay. Oh, so I have plenty of time. Okay.
Yes, ma'am.
So I was really excited when I saw this question, and thinking about it made me think back to a conversation that I had with one of our community advisory council members as part of the listening tour that I embarked on ahead of taking on this role as director of our Center for Community Health and Prevention. And this is a body, our Community Advisory Council, that has been meeting for well over a decade. And sitting down with this gentleman, a member of our CAC, he said that he felt the engagement that he had been involved in to be episodic, that it was characterized by episodic interactions, that he felt as if him and the rest of the group were being experimented on. He believed that the meetings were a lot of reporting out. And what really resonated with me was that he said, I was never told that my voice was valued. And that statement stuck with me. So coming into the Center for Community Health and Prevention as the director, I had an objective for the center to be a more effective bridge between the University of Rochester Medical Center and our larger outlying Rochester and surrounding area community. And part of becoming an effective bridge, I believe, is really solidifying authentic relationships with our neighbors, with our colleagues, with our friends, with those we live among and with. And really, we always hear about, building trust and rebuilding trust between the university and the community. But I don't know that all of us take the necessary steps to really make that happen. So as I stepped into this role in the pursuit of health equity, I knew that that was going to be a foundational piece of my role and my leadership of the center. So to begin to do some of that, I knew that just simply showing up was going to be critically important for us to be visible. So one of the first things that I developed in partnership with the Director of Community Health Partnerships within the center was an effort that we have titled Time is Treasure, which is mainly an internal it's an internal effort just to encourage our faculty and staff within the center to get out and be part of things in the community, things that are not necessarily part of their job, or their everyday experience in the center, but just ways for them to get to know and connect with the community that we are serving and that we are part of. And so how I framed it to my staff is that this is an effort to understand the why of what we're doing. We can't sit in our building and wait for people to come to us and do what's written down on a piece of paper. We need to know people. We need to understand where they are and what they're coming in dealing with and all of that context. And we can't possibly understand that without immersing ourselves there. So that's been something that's been very important for me to institute within the center. In addition to that, our efforts to diversify our workforce within the center. And I have been very happy with our progress in that area, not only thinking about, okay, hiring, this person because they have certain demographic characteristics, but really making sure that we are representative of a diversity of lived experiences on our staff. And that just increases the welcoming atmosphere of our unit, if among other things. And so I'm pleased to say that we currently have employed a community health liaison who is actually helping spearhead some really important grant concepts. We also have a community health worker who is working very closely with the associate director of our Office of Health Equity Research. So she has worked very closely on issues related to the health of those who are exiting the incarceration and criminal legal system. So she has that background in working within those systems. And then we have myself, we have other administrative staff who have increased their effort in their roles, who are pursuing higher education, and we are very supportive of promoting from within. So providing training opportunities and ladders for them to pursue additional roles within the center, among other things. And then in addition to our Time is Treasure initiative and those efforts to diversify our center's workforce, I am all about listening and responding. There's one thing about asking, for community input, and writing it down and putting it on a shelf. But my approach, which a lot of people here and many I'm sure who are listening, is that we engage in conversation and I listen and I carry it with me and then I take action. And most times it's immediate action. I start spinning the wheels and we start to work to get some things done. So that's my approach overall, but I would say that is still going to propel us towards the achievement of health equity more broadly. So I hope that answers that first question. And
It
thank
does.
you.
It does. Very robust answer. Thank you for that. Just in another like 20 seconds or so, with your broad approach to health equity, how would you rate its effectiveness?
Oh, that's a tough one, Gary.
No problem.
I would probably rate it at a 7. And I never give anything a perfect score because it was out of 10, correct? So I never give anything a perfect score. And I think that I rate it a 7 because with all of the good intentions and all of the momentum right now, it still requires buy-in. It requires agreement. It requires partnership. To be truly effective. And so I am going to do everything in my power to make that enticing and relevant and all of the things that need to be there for this to be something that is of value to those that we really need to be in partnership with for things to move forward. But then, that's as far as I will be able to go. But I am one who is always there for it. I am there for the input. I take the constructive criticism. I am, well equipped and well versed in having to go back to the drawing board and be told, no, that doesn't work for us over here. So I'm at the ready to do that as well.
Excellent. Thank you so much for that. Oh, I
Mhm.
don't know what that was. Sorry. I'll mute myself. All right, perfect. Thank you for that. Thank you for that very robust answer, Dr. Edith Williams. Next, I have Angelica Perez Delgado. I have a question for you. How are you today?
Doing great. How are you?
Doing well. Can't complain. All right. Well, my question for you, Angie, if you don't mind.
Yes.
You are the CEO of the largest Latinx serving organization in Monroe County. We are aware, and it is important to point out that Ibero does not only serve the Latinx community. Given our topic, what are some of the challenges that you face regarding health equity and access to the social determinants of health?
Yes, great question. So I think similar to what Dr. Edith Williams was saying, you know, ditto, like being in community access, believe it or not, we like to think that healthcare is accessible, but for a lot of people that can be a real challenge. So for us, in our perspective at Ibero, a couple of points is language access, because we do serve such a large population of folks, not just here in Monroe County, but across upstate New York. We have sites all the way from Albany to Niagara Falls. One of the things that we find is the first thing that happens to the population we serve is the lack of language access. I often ask folks, how are you able to make an informed medical decision if you are not fully informed in your native language? So bringing up those language services in all of our institutions are very critical. And as we diversify as an institution, serving a lot of people of other languages, we have seen firsthand, how difficult that is to be able to serve people from multiple language in a way that really honors our values. So we've partnered and worked really hard to have a robust language access, and all institutions should be doing that as mandated by the law. There's an actual law. If you are billing for Medicaid, if you're receiving state funds, you are required to have a language access plan that is executed in your institution and can be tested at any times. So that's a big one for us. Another one that goes along the lines that Dr. Williams was referring is being culturally responsive. When you're working closely with community of color, we go about our healing in a very different and holistic way. I always say, we're going to start with the aunt, the grandma, then we may move on to like distant family. We'll go to the priest probably before we go to like a mental health therapist or any of the traditional services that are provided in a medical institution. I was just chatting this morning with another leader in our community about the home remedies that our grandmas used to give us to heal us out of certain things. So I think recognizing that those are real components for us. And then when we're showing in healthcare systems that tend to be very transactional, we're very relational. And that often, I think, breaks the connection that can really impact health outcomes. And we already know that most of the healthcare actually happens outside of a hospital system. So how do we bring those services into the neighborhood to the people and educate people? Like for us, our big initiative is promotores de salud, community health workers. How do we build those expertise within community so that when I'm going to go talk to my neighbor Maria about that headache that I've had for the last couple of days and how I'm feeling, there's some ability for us to support each other through that, because that's likely what we will do before we end up at a hospital, before we end up engaging with the healthcare system. Another one is, that community rooted. I think some of the disadvantage with health outcomes is we wait until there's a health crisis to engage with community. And one of the things that I've always said is you have to engage with community every day so that when those moments come, they know you, they trust you, they understand the services that you're providing, and it's an easier engagement to pull forward because that relationship has already built. And unfortunately, a lot of times we just don't spend enough time building those relationships with community.
Absolutely. Thank you for that answer. That was great. Certainly appreciate that. All right. Lonnie Haynes. The great Lonnie Haynes with the multiple job descriptions. Perfect. Sir, I have a question for you.
Sure.
In terms of Rochester Regional Health, currently facilitating several health career workforce trainings for adults and youth. How can this effort address the social determinants of health and advance health equity?
Yeah, so really going back to what and Angelica said, and of course Dr. Williams said earlier, when we talk about social determinants of health and we talk about health equity, the data shows us that patient outcomes are best addressed or best attended to by individuals who are culturally competent, who are culturally sensitive, and that means having a workforce that's much more diverse and inclusive. And so our goal is to make sure that we're being inclusive when we're hiring, just not only around race or ethnicity, but in gender, but people with disabilities, individuals who are veterans or military. You need a diverse population of employees and clinicians who understand all the nuances of the various communities that we service. For example, around the LGBTQ plus community, do you have individuals who understand affirming transgender care? Do you have individuals who understand what type of care you should be able to provide within that community for women or men who are LGBTQ plus? And that requires having employees who understand that, not specifically who identify in that space, but who have experience working in that space. And it's great if they do identify that. But our goal is to make sure that those individuals who understand those different populations and communities are part of our workforce. And that is an intentional effort to go out and look for that diversity. And diversity is growing as we grow as a country beyond, again, race, ethnicity, and gender, again, religion, country of origin. In some instances, in this part of the country, it could be the region of the country that you're from. I'm originally from Georgia, from the South, and having someone who understands certain Southern traditions and Southern culture, that's diversity. Having someone who's from a different part of the world, understanding that is diversity. And so we're very intentional about being aggressive about hiring diverse talent to impact the workforce, thus impacting the outcomes of our patients.
Excellent. Thank you. This question is for Dr. April Aycock.
Hello, how are you?
Hey, I'm doing well. How are you?
Wonderful. Thank you so much. Had a
Excellent.
good
Excellent.
lunch and I'm ready for this esteemed panel.
Well, all right. Well, all right. And a sidebar, I see pink and green there.
Yes, you do.
Oh, okay. So you're first fam. Okay. Understood.
Yes, I
Perfect. Perfect. See,
am.
yeah, I
To
knew
the
that
day
connection
I
was there.
die.
I knew that connection was there. All
It's
right,
in my
perfect.
blood at this point.
No doubt about it. All right, perfect. The question I have for you is as follows. The data and reports continue to highlight disparities and inequities related to mental health and trauma in our Black and Brown communities. Are you seeing any improvement in any of these metrics? And if so, what's working and what's not?
So this is a really good question, and it's a little bit, I'm going to tell you what's working and what's not working. I would say that we are seeing some improvements, but the numbers are still very daunting. So when I look at the SAMHSA National Survey in Drug Use and Health report, it indicates that 57.8 million individuals 18 and older are experiencing mental illnesses. Out of that, 46.5 million individuals receive actually mental health services. When we break down those numbers and we go into the Black and Hispanic population and Asian population, those numbers get lower. And the reality, to say why is that, right? Because I'm always asking why, always have a lot of questions as to why. Where research shows that most of the minorities in the United States are more likely than whites to delay or fail to seek mental health treatment. And after entering mental health treatment, right, they're more likely to not receive the best treatment. Again, I'm going to say that again, the best treatment in particular for depression and anxiety. And when we do enter into treatment programs, a lot of times we are terminating the treatment prematurely. And there are multiple reasons as to why this is the case. One main reason is still that historical stigma and harm that has occurred in our communities in the name of research and in the name of behavioral health. also our population is either underdiagnosed, misdiagnosed, or diagnosed with schizophrenia. So then again, why would I want to go into treatment? I heard one of the panelists say, can you tell me about what's going on in Georgia? You know, if you're having a conversation with me, do you speak my same language? So what's working, right? Now, again, we have a long way to go, Gary, but what's working is that we're starting to see more of an increase of anti-stigma awareness. And we're starting to see a lot of people talk about mental health and addiction, and they're saying it's okay not to be okay and to start to seek help. So that is huge that we're seeing more and more. There's a 988 crisis and suicide hotline that you can call at any time of the day and you get a live counselor. We're seeing people actually utilizing those services. We have for the first time a governor who gave 1 billion across multiple years to try to transform the mental health service delivery. We're seeing more treatment programs say we really do have to lean in more to culture, humility, and diversity, equity, inclusion, and belonging in trainings. We're seeing more openness to what other treatment interventions are out there to accept that. I heard Angie say, you know, you got to be in our community. So there's billing codes for community services. So actually going into the community where the people are. So seeing more of that from providers. We're seeing more of integrated mental health and substance use programs underneath one clinic, which pretty much means that it's a one-stop shop. I like to look at it as more of a Walmart. You go there, you get everything that you need, and then you can go home in treatment programs. We're seeing more peers with lived experience. That was our keynote speaker today, talking about lived experiences, right? So that's working well. And we have the telehealth options that has also been able to stay here. We're also seeing an increase of Black clinicians going into private practice. We're seeing more ability for tuition reimbursement and internship stipends within the field of behavioral health to try to encourage more Black and Brown individuals into the workforce. So those are some of the things that are working. So let me talk about what's not working, because that's important to highlight. What's not working, of course, is the language access, and Angie mentioned that. I do not want to be in the room with a telephone with another person to have a conversation with that person. I'm sorry, I don't. So again, the capability of that is lacking. What else is going on is we don't have a lot of services that are embedded in the communities where people are at. So that's important. When I look at our community, I see more liquor stores in the communities than I see behavior health services within these communities. What's not going well is the reimbursement rate. There's higher, you get paid more for the reimbursement rate for Medicaid than commercial insurances. There's still a huge discrepancy with mental health services pay reimbursement rate compared to substance use pay reimbursement rate. That's something that should not be. We continue to hear the word, we want evidence-based treatment instead of practice-based treatment. If you look at that in the research, the participants are mainly non-Black and Brown individuals, but yet we are using this treatment model for Black and Brown individuals. Workforce challenges is continuing to be a huge issue, and we're starting to see a big, great Black therapists flee from public behavioral health programs. Now, I haven't seen that in research, so if somebody tries to use that, make sure you just give me credit. Don't coin that. But we are seeing a flee of clinicians going into private practice because they're not feeling that belonging culture, or they're not getting the wages that they deserve, as well as the autonomy in programs is what a lot of Black clinicians are reporting out. A couple more I'll give you is that we have a lack of addressing the historical scars that have been imposed on Black and Brown communities. And I know I mentioned that earlier, but again, we have to continue to acknowledge that because we still have a lot of our grandparents and individuals who know about what has occurred and continue to tell the stories within around our tables. We also are seeing, and I believe one of the panelists mentioned, just a lack of Black and Brown leaders in these programs. So again, you go to somewhere and you don't see people who look like you. We are also seeing restrictions within fundings. So again, those practices is definitely encouraging the disparities. And lastly, Gary, if you may allow me, I don't know how much more time, but lastly, I would say is that we still have quite a bit of systemic barriers within legislations, within policies, within practices. I mean, when you look at the whole cocaine and crack disparity, it's still there. To know that a person can be incarcerated, their insurance is cut off. So when it's time for them to enter into a treatment program, guess what? They don't have insurances. So these are some of the things that is working and not working. We are addressing things, but we still have a very long way to go.
So thank you, Dr. Aycock.
You're welcome. I got passionate with that.
Yes, you did. And that's all right. That is all right. Next, Mr. Anthony Jimenez, I have a next questions for you. How are you today?
Good. How are you doing?
I'm doing pretty good. I can't complain. All right, so my question to you is as follows. What are some institutional and community-facing strategies you recommend for advancing health equity?
Yeah, I really appreciate this question. So, I mean, just a little bit of where my response to this is coming from. A lot of the way I think about institutional and community-facing strategies is basically what do I teach my students? So I'm a professor at RIT, and I get this question all the time with students as well as what can we do, right? So, I think that where I want to start with this question is basically the acknowledgement that every single person that's watching and tuning into this webinar that we're participating in is fully capable of manifesting health equity. I think that there tends to be the assumption that we don't know enough, we're not skilled enough, we're not capable enough to actually manifest health equity. And I want to dispel that very, very quickly and say that every single person watching is capable and has some sort of skill, some sort of experience that they can share to manifest health equity. So in terms of some institutional and community-facing strategies that I would recommend for advancing health equity, really, I've kind of narrowed it down to three things, and they sound very basic, but they can be expanded. And the first one is to read, to basically read about what's been done. Right. I think we often end up trying to recreate the wheel when it comes to health equity and health justice. A lot of people tend to feel incapable and sort of lost in where's the good starting point. We have a lot of great models for decades now, coming all the way back to the civil rights era about what people have done to manifest health equity and provide health resources to those who the healthcare system wasn't designed for, quite frankly, right? And so I think reading up on these strategies, reading up on what's been done, what's been effective, is really, really important. The second thing I would recommend is connection, right? And this really echoes what I think all of the panelists have said at this point, is that it is important to be in community with folks. It is important to engage with the community. I think that if there's one thing that we could do for everyone in this webinar, it's to connect to one organization, just one. You know, if you connect to more, that'd be fantastic. That's great. But in 2025, there's a lot of scary things happening. Let's keep it small, right? If we connect to one organization and be a part of their efforts, I think that's a really, really important thing to do. Because there's a lot of different social determinants of health that we could latch onto and try to address, whether it's homelessness, food insecurity, educational disparities, all of which are tied into health equity. And the last thing that I'll say, the last recommendation that I would offer is to commit, right? I think that, you know, we read about the background, we connect to an organization or two or more, and the last thing to do is commit to these organizations, commit to these spaces, whether it's just an hour a week or one day a year, whatever the case may be. Organizations and people that are part of these spaces, it takes a lot of work to make things happen, right? And so committing whatever time and labor that you can provide, I think is a really, really valuable thing to do. And so that would be my third recommendation.
Excellent, excellent. Thank you. All right, I'm going to circle back to Dr. Edith Williams. Dr. Edith Williams, in about 5 minutes or so, could you squeeze this a lovely answer in for this question? Given the numerous health disparities that currently exist, is there any ongoing research that is centered on improving outcomes for Monroe County's BIPOC residents or BIPOC people in general?
Absolutely. So I wanted to begin with the fact that we just recently completed an inventory of all of the health equity related projects happening at the University of Rochester. We accessed information from a number of sources and came to find that about 19% of all of our funded research projects could be classified as health equity projects, and about 13% of our overall projects, because you have to keep in mind some things are internally funded and not always externally funded. So about 13% overall of our projects were health equity focused. And while we didn't drill into the characteristics of the populations being served by these research studies, we do know that being classified as a health equity project, they generally are addressing needs within populations that have been underrepresented or marginalized in some way with regard to the social determinants of health, usually socioeconomically deprived or marginalized populations, which unfortunately in our country is predominantly our communities of color. So while we can't definitively say every single one of these projects was BIPOC community focused, we can say that they were focused in areas that did relate to being in the pursuit of health equity. And I wanted to, in response to this question, first of all, highlight just a handful. So you can imagine 19%, 13% of projects, those are hundreds of health equity research projects that are happening at our university. So I wanted to just highlight 3 of our investigators to just give you examples of the type of work that's going on. And the first is Dr. Eddie Schwartz, who many people know. He's Burton Professor of Orthopedics and the director of our Center for Musculoskeletal Research here at the University of Rochester Medical Center. And what I wanted to focus in on with his work is that over the decades that he has been funded to do the work that he does in orthopedics, he has been focused on culturally competent care. That's a different spin on research. And where he has been focused is really looking at if we train our healthcare professionals to be more culturally competent, how does that impact the care that is delivered and received? And how does that then impact the subsequent outcomes? And so the findings from his work has suggested that training our healthcare providers in that way to understand and respect cultural differences really enhances not only patient-provider communication, it improves patient satisfaction, and it also leads to better adherence to treatment plans and subsequently better outcomes. We also have Dr. Sherry Toth, who many people are familiar with as she has directed the Mount Hope Family Center here in the city for some years. She has retired just recently, but previously was the professor of clinical psychology and psychiatry. She has been continuously federally funded since the 90s. And what I wanted to focus in on in her work is that she has focused in on maltreated children and families, not only the families that these children reside within, but particularly their mothers and the parents and their mental health status, and trying to help families through their individual journeys in that way. And along the way, and being continuously funded to support those families, her research activities have uncovered a number of different approaches that have been replicated and are being used to inform strategies across the country. So some of her findings have to do with her research on child welfare policies and practices. Her work has informed the advocacy for the importance of addressing parenting behaviors in interventions, not just focusing on the children, but really focusing in on the health and particularly mental health of parents. And in these interventions that are really aimed at protecting children from abuse and neglect. And her work has informed practitioners, particularly about the necessity of supporting at-risk families to prevent negative outcomes for children. And then the last investigator that I will mention is Dr. Jill Halterman, who is our current chair of pediatrics, and she's also our physician in chief for Golisano Children's Hospital. Dr. Halterman has also been continuously funded externally by the federal government over the last 20 or so years. And her work has focused in on improving asthma care and reducing morbidity as it relates to asthma. And with regard to a focus on health disparities and health equity in her work, her research has shown that children from low-income families are disproportionately affected by asthma. And her interventions aim to provide equitable care across different socioeconomic groups. She has had phenomenal community-based approaches to providing that care, working with school districts and nurses' offices within schools, and the models of care and treatment and community involvement and continuity across different areas, home, school, rec center, et cetera, have been replicated nationwide. So that's giving just a spotlight on a few of our investigators focused in that area. And I would love if I had more time. I'm sure my 5 minutes are coming to a close, but there are also some hot off the press areas that aren't necessarily ongoing at this point, but definitely up and coming foci of research that are linked to the priorities that our community has expressed as those areas of highest need and highest priority. So we are also approaching those areas that include housing, substance abuse and mental health disorders, the prevention of gun violence, the prevention of reincarceration, and the prevention and management of chronic diseases. And so there are a plethora of research concepts and development to actively address and respond to those community articulated needs as well.
Perfect, perfect. Thank you, Dr. Williams. Thank you. All right, next question is for Angie. Right. Advancing health equity in the Latinx community will require all systems to prioritize improving language access. What are some key strategies to advance this work?
Yeah. Well, I think we start by increasing our representation in the healthcare roles and fields. I think investing in more Spanish language or bilingual of any language, nurses, healthcare providers is critical. I think that's probably one of the best ways to ensure, right, that language access is prioritized by investing in that community, in those communities. And I know we have a lot of efforts locally to increase our LPNs, our RNs, and some other healthcare fields representation of these populations, but that's the best. It's really hard for those who don't speak another language or do not prefer to communicate in another language than English. It's really hard to talk about some of your most personal issues with a third person in the room. It takes away the privacy. So ideally, I will always say, if you're serving a large community that requires a specific language, then you should be out there in that community finding out who can fill those roles so that you are bypassing some of those other things. When that cannot happen, obviously, investing in a language access plan is really, really important. And that requires money. I mean, to be honest with you, if you don't have a budget for language access, if you're not putting your money in language access, then you're not probably providing a robust language access service. So making sure that that is a budget line for you. And that's really important because language access is expensive, especially when you're doing it right, is quite costly. It requires multiple ways to be able to provide that access through language. So people need to really have an investment around that. My other thing is also investing in community health workers and promotores de salud. There's been a lot of research for a lot of decades that already show the return on investment that we get on community health workers when it comes to getting preventative care and chronic disease management care in the forefront. We saw that play out in COVID. So really making that a priority in all of our institutions to make sure that we're training community health workers to be, I mean, to me, those are the best ways to ensure that language access is priority. Hire people that can speak the language of the community that you're trying to serve, invest in developing people so that you constantly have that pool, and invest in your community, put those resources and have a budget line for all of those things. Until we don't do that, we will always struggle with providing the appropriate and the legal right of the availability of services. I mean, it is the legal right to be able to receive services in your language, whether through a language access plan or having a provider that can speak your native language. So I always take everybody to that. We're not talking about extra or the icing on the cake. We're talking about meeting the minimum requirements of the law. If you are being funded by the state, you have to have a mechanism in which to provide access.
Excellent. Thank you so much. Thank you. All right, next question is for Mr. Haynes. With the changes ahead in leadership at the federal level, how do you see large health systems like Rochester Regional Health continuing to prioritize health equity and workforce diversity?
It's a great question, given what some of us have coined the impending storm. We're committed at Rochester Regional Health, and I know a lot of other organizations are also, but we're committed to continue to do the work that we've been doing in the community. We operate in a very diverse community throughout greater Rochester area and upstate New York. And our goal, our strategy is to maintain the work we've been doing, addressing health equities across all areas, despite any changes that might happen at the federal level. Our strategic goal internally, again, addressing SDOH, social determinants of health, addressing health disparities across all the communities. And I would imagine what we'll be hearing soon from the Centers for Medicaid Services and our other federal agencies, what their goals are specifically when it comes to health. But we will align ourselves with what their requests and what their recommendations are. But at the forefront, we are community health, and we're going to make sure that we're providing that experience that our patients need in the diverse communities that we operate. It'll be interesting to see what happens in the next few months. We have thoughts, and we're hearing comments from some of our partners and some of our stakeholders at the federal and state level. But again, we're addressing community health and what that looks like and how that comes out. We're going to make sure that we're doing what we need to do when it comes to dealing with those health disparities and social determinants of health.
Excellent, excellent. Thank you for that. Next question is for Dr. Aycock. Dr. Aycock, what is your analysis of the intersection of mental health care and access to social determinants of health for those experiencing poverty in Monroe County?
Yes, great question. The intersectionality of mental health and social determinants of health, it really highlights the complexity of a variety of different factors that can significantly influence individuals' mental health, especially people that are experiencing poverty. Just want to give you some more numbers real quick, but when we look at this, the White House did a report and it indicated that people who experience psychiatric disabilities, they were actually the largest contributor to the growing Social Security disability insurance. So what does that look like? It looks like 29% of the beneficiaries needed support, okay, because they could not work. What's the number for that? That would be 2.4 million people. That's larger than people who are out of work due to injuries, cancer, and different kind of diseases to the circulatory and nervous system. So when we look at it locally, when I look at it locally, I say, how does this look, right? How does this look within our system? Is poor behavior health. It looks like poor school, poor work, relationship outcomes. Also increase mental health and behavior health symptoms. Delay in clinical care. We see rescheduled or missed appointments, lack of funds for internet access or broadband internet accessibility to be able to do telehealth. We see, of course, the increase of misdiagnosis and underdiagnosis. Again, if somebody does not have stable housing and they come see you and they're nervous or they cannot sit still, and the person is being diagnosed with, for example, ADHD without taking into the consideration of living environments, and that response may actually be a protective factor. For example, we'll see again, delayed or missed medication use, lack of preventative intervention services, as well as practice-based services, lack of insurance as well, that factors into this. And for us, when I look at the community and providers that are providing support within the area of mental health and substance use, most of our programs do provide case management, vocational counselors, peers, and resources to try to connect people to some of the social determinant support within the community. They've been doing this for years. The problem is that most of their reimbursement for that is low. So a lot of programs are taking it out of their budget in other areas, which means if you're taking it from other areas, there's a lack in another area. Lastly, I want people to keep in mind and focus on this because this is happening within our community. It is the 1115 waiver social care networks that is within our community. You're going to hear more and more about it. It was actually approved by the Center for Medicaid and Medicare. It is the New York Health Equity Reform. So they're looking at social care needs, especially in the area of food insecurity, housing instability, and lack of transportation, and make it billable so that then Medicaid insurances will pay for these services. So it's going to be important to just keep your eyes out on that within our community. There are some different logistics associated with it, so it's going to be important to keep our eyes on that. Why is this important when we address social determinants of health, especially within our community? Is that research shows, and we've seen it when we was during COVID, when people received more money, what we saw was that it actually improved in health, and it improved in decreasing food insecurities, and it actually helps to lower health costs in the long term. So I hope I was able to answer your question. And now I think I have 5 minutes.
No, that was great. Thank you so much. All right, perfect. For Mr. Jimenez, I do have another question for you.
Sure.
My question is as follows. You've done extensive research on immigrant health disparities. What does your work show us about various social determinants of health and efforts towards health equity?
All right. Thank you so much for this question, Gary. I really appreciate it. Yeah, so I have done extensive work in immigrant health disparities. There are over 11 million undocumented immigrants in the country right now. My research is largely about how undocumented immigrants are navigating the healthcare system and accessing care. And so what my research has found, what I've seen is that undocumented immigrants, perhaps unsurprisingly, are among the most multiply marginalized populations in the country. meaning they're disposed to the most social determinants of health than any other population in the country. And what I've seen is that in sort of comparing what I've found to other studies and what we know about racial, ethnic, and gender and intersectional health disparities in general, is that the experiences of undocumented immigrants in particular tend to be a preview of the experiences that that everybody will eventually experience, and that's non-citizens and citizens alike, right? And so I think that what undocumented immigrants' experiences teach us is that there's a lot of work to be done in relation to every social and healthcare safety net that we have at our disposal here in the country. And I think that there's reason to believe with the incoming federal administration, and I think Lonnie Haynes kind of alluded to the impending storm, there's reason to believe that every social and healthcare safety net that we have now will undergo further deterioration or withering over time. And so what this has meant for immigrants in particular has even more food insecurity, even more crises in relation to housing, educational access, and healthcare provisions generally, but long-term care particularly. And this is an area that I think that it's important for us to be particularly attuned to for citizens and non-citizens alike. Long-term care is completely lacking the type of support that is needed right now. And what my research has shown is that immigrants have had to sort of create systems of their own in order to survive, which is both challenging, but also sort of the light of what we're trying to look for in terms of health equity. I strongly believe access is important. I don't want to discount that at all. But I do think that this healthcare system has shown us time and time again that it's unsustainable, especially under sort of a capitalist logic of making profit and protecting profit for folks, right? Multiply marginalized populations have been creating their own systems of care, and that is how they have been surviving. And I think it's through these experiences and stories that we can learn from to sort of rethink what could healthcare look like in an alternate future, right? So I'll leave with that.
No, thank you for that. Thank you very much for that response. Very, very, very robust. All right. So I do have an extra question to which I will ask each and every one of you to give a minute to respond to the question, and I'll it goes as follows, and I'll begin with Dr. Williams. So ABC's 60th anniversary theme and this signature conference theme is empowering communities, inspiring change. How have you leveraged your role to advance health equity while addressing social determinants to health? And I'll start with you, Dr. Williams, if you don't mind.
Sure. Well, I do not take lightly that this role affords me seats at tables that I normally would not have. And so, as I have been invited to those seats, I bring the community with me physically, whether it's stories, whether it's data, whether it's partners coming with me arm in arm. I take that with me. I never have a conversation. I am never part of a presentation where the needs that have been articulated to me or the offices that I lead are not presented as part of whatever I am speaking about. So I try to do that in the roles that I've been afforded. And in the same way, I try to make sure that whatever work that we are doing is work that's resonating with the community, that it's things that we have been asked to do, we are being responsive and action oriented. And I'm scrambling a little bit because I know a minute is a really short time. So I hope that that's that's answered your question.
It has. Thank you. Next, Angie.
Sorry, I had something in the way.
Understood.
I'm sorry, repeat that again.
Sure, sure. How have you leveraged your role to advance health equity while addressing social determinants of health?
I think just, educating my community, educating all the systems that come in touch with my institution and the community. I've learned to be unapologetic about the needs of the community that we serve. And also being a bridge. I think that's, Dr. William Edith said it best. When people of color and people like us come into these roles, I think it is really critical for us to always be focused on how do we get to the best outcome. And I know it's easy to become frustrated. I vent a lot. There's a lot of situations. I remember during COVID, I've never been so frustrated, I think, in my life and deflated when COVID happened. But it was also a great opportunity to put all of that aside, put all your partners together and do what is good and what is deserved for our community. And we really saw that play out through COVID. And as we talk about the impending, everything that's coming our way in the next year, especially for our migrant and our immigrant families, we're going to need that more than ever. So I will always leverage my role, my institution, the power and the influence that comes with Ibero to make sure that we're advancing those outcomes for our people. Otherwise, there's really no point to be in these roles and to do the work that we do. So that's the commitment, that I make.
Excellent. Thank you. Thank you. Mr. Lonnie Haynes.
Yeah, so both Angelica and Dr. Williams have two of the areas I was thinking about, about being unapologetic about my voice and being representative, especially in this environment that is anti-woke and anti-DEI. I think, DEI and all that it is has become a political piñata. And so sometimes we're concerned about how we show up and arrive in the room. But I think to Angelica's point, being unapologetic about why we're here, that we're a voice that articulates for other communities and other marginalized populations. So that is what I've done. That's what I will continue to do. If we can't do it, then we shouldn't be here. And so my mantra has been and continues to be is everyone in the room and making sure every voice is heard in that room, especially for marginalized communities.
Excellent. Thank you. Thank you. Dr. Aycock?
Yeah, so I echo what the panelists have communicated. I'll just really highlight a couple things, which is people who generally know me know that I really do live by Miss Ursula Burns' quote, which is, I didn't learn how to be quiet when I had an opinion. The reason why they knew who I was is because I told them. Everybody knows that I look through the world with equity and how can we improve the community as a whole. And so I live by that. I also am able to do what I do by being at these tables and providing feedback and helping people see the bigger picture of things and how we can change is because I have an incredible team that really, really, truly are invested in how do we help out our community as a whole. And I'm really blessed and honored to have that. So again, I sit at different tables. I'm privileged to do that. But what's important is really looking at things, reading different documents, being able to look at the fine print of things and giving the appropriate feedback is so important in this role. So thank you.
Thank you. And lastly, but certainly not least, Mr. Jimenez.
Thank you for this question. So I mean, my role is, professionally is as an educator. I'm a professor at RIT. And so how I leverage that role toward health equity, very clearly through teaching about health disparities and what health equity, health justice could look like. But I think in my role, what I really enjoy doing is challenging students, and really others, anybody who, anybody who wants to listen, right? That anyone, like I said earlier, is capable of manifesting health equity. There are plenty of people on this call who may be health professionals. There are many people who may not be affiliated with healthcare in any way, shape, or form. And it's really for the latter group that I would say that, like, we all have the ability to work toward health equity. I remind my students that are, engineers, that what they do matters toward health equity. Students who are, geared to become urban developers have a lot of responsibility toward developing the city in a way that's amenable to a healthy lifestyle, and to addressing what we know to be robust racial, ethnic health disparities. Regardless of what career path my students take, I try to remind them and teach them the ways that they can think about their roles critically, how what they do matters in terms of perpetuating further disparities, or conversely, manifesting health equity.
Excellent. Thank you. Thank you. Looks like we have a few questions from the participants. Mr. Underwood?
Yes, we do. First of all, thank you to this amazing panel and moderator. Thank you very much for lending us your talent. We have several questions in the chat, and we'll start with Dr. Jimenez, where you just left off. There's one specifically directed to you, and it references your comments where you mentioned there's a bevy of information out there that one could read with respect to health equity and what was done historically. The question is, do you have a reading list to get folks started reading on community strategies to address health equities? So you could talk about that, and you could also even post-conference send to us, and we could send out to everyone, but I'll let you comment on it right now.
Sure. No, it's a great question. So I mean, that's the type of question that I dread, because it asks me to list a range of different books at the top of my head, and I feel unable to do so. But I'd be happy to put something together and share with the group to see if we can, share with the acknowledgement that it's a working list, and that we should all add to it. I think that when it comes to community health work particularly, I mean, I was told not to do any self-promotion, but I will say that I did co-author a book with a couple of folks called The Third Net, that I would advocate, that discusses particularly how different community spaces are addressing immigrant health disparities. So if that's a particular area that folks are interested in, I would definitely promote that book. I apologize for the shameless promotion there. But I can definitely, again, I can share some resources with the broader group at a later point.
Sure, excellent. This question, I would say, is for everyone, but I think particularly more so for doctors, maybe Aycock and Williams, as what I call the technicians, and probably Dr. Jimenez, who I don't know as well as the other two. And Dr. Williams, in particular, you mentioned, if I'm not mistaken, I think I wrote on 19% of research that's going on at URMC could be classified as health equity related. And there's a lot of work going on in health equity, and Dr. Aycock mentioned about some things that are working. The question is, and this one is for me personally, why aren't we seeing the needle move with respect to having the disparities decrease? We know health disparities are a big thing, and the good things that we're talking about it here now, but beyond that, when can we reasonably, this is part two of the question, reasonably expect to see some of those needles moving on the things that are hot button items in this community, like maternal health and infant maternal health, infant mortality, things like high blood pressure, diabetes, the things that we know have disparate impact to people who look like all of us on the screen? And everybody can sort of opine on that.
Yeah, I don't know if there's someone who wants to go first, April or Anthony. I'm happy to jump in though. Okay, I would say, in my opinion, Jerome, that as much as we want to see immediate change, many areas, it takes a really long time to see change on an ecological level. So we may have the best interventions in a number of neighborhoods, but for us to see numbers shift at the million, hundreds of thousands and millions, it takes time. And so we see tiny wins that incrementally will build to that point. But I think that a lot of us become impatient. And if it isn't happening in 1, 3, 5 years, we think that nothing is happening, but we aren't necessarily recognizing the incremental progress. So I think that's the space that we're in. Now, that is not to say that that is about everything. I also believe that there are areas of high risk and high reward where we could push the envelope and be very daring. And a lot of people are more conservative and scared to take those steps to just say, we are going to go out on a limb and do this, which could produce more immediate change, but it's risky. And no one wants to be liable. And so then we get into those situations where we're holding back and moving slower, out of, to be more conservative and to make sure that, there aren't casualties in the process, if you will. So I think there are a few things working against that type of rapid change that we all would love to see. And that would be my input, and I'm sure my colleagues have other things to add.
Thanks, Dr. Williams. Dr. Aycock?
Yeah, I actually agree. I agree with Dr. Williams on that. I just want to point out just a couple things that I'm noticing is pay attention to funding and who's getting funding. That's important. And so when we want to say move the needle and you start seeing people getting in organizations that are not predominantly serving the African American and Hispanic population, you got to scratch your head and say why. Okay. The other thing that I notice is there's a huge distraction when it comes to data. It's always, we have to start by getting the data, despite the fact that we already see the numbers with our data. So it's always kind of a, where do we start? Where's the playing ground of that? That continues to play out whenever I have these conversations of, we already have the data. And most of the data are individuals who are in our cemetery. And those individuals who have to have limbs cut off or going blind or stuck in the criminal justice area. So those are two factors that I just want people to pay attention to when we do have these conversations. But I agree with everything that Dr. Williams communicated. It is going to take some time.
Thank you. Anthony or Lonnie wanted, or even Angie, add anything to that?
Yeah, I just want to ditto what Dr. Aycock said. I think we want change, but the powers that be are never really willing to give their power to the people who can truly create change. And for me, that lies at the community level. We do a lot of talking about bringing the community to the table. Just because you're in the table doesn't mean that you actually have a voice. Just because you're in the room where the decision happens doesn't necessarily mean that you have the power or the influence to be able to drive that decision. So I think if we want to, I agree with Dr. Williams, change takes long, but there are real opportunities where we can pilot and we can test, but there's just this unwillingness to give the power to the people that can. I guarantee you that if we took a pot, if we were like all really serious, I don't have any money, so it can't be me. I borrow, we're broke. And we already know that BIPOC nonprofits are stretched to the limits, right? In Spanish, we have a saying that says, out of tripas corazones, it probably will not translate well, but out of guts, we make hearts. And that's what agencies like mine, like yours, like Jordan, that's what we do. We make tripas out of corazones. So I challenge, if we were to ever get a pot and give it to the people. And research already shows this. We learned this through cash assistance. When you give people money, they make great decisions for themselves because nobody wants to be a poor health and broke. So for me, it's, that's the real issue, that the powers to be are unwilling to default their power to the people who can actually create change. And we do have to be patient, though. If you're not able to give us that power, then for us, we have to be able to go to that long game. It's a long game to health equity. And we have to be, as leaders, BIPOC leaders in this community, be patient, willing, and manage our frustrations so that we can take our community to where they need to go.
Thank you. And before I forget, what you said just now, Angie, reminded me of something that Anthony said earlier. Anthony, I'm going to come back to you, but Lonnie, I'm going to have you go next because you had your hand up. And that thing I want you to come back to, Anthony, is when you said marginalized groups have been creating their own systems of care. I think that relates to what Angie was saying. So we'll come back to that in a second too, if you just elaborate a little bit more about those systems of care, making something out of nothing. But Lonnie, go ahead.
No, I really just to echo to Dr. Williams and Dr. Aycock and of course Angelica. You may find pockets of wins, whether it's reducing the A1C or diabetes in different communities. I think there are wins in different communities at different measures. But I was just thinking as you posed the question, Jerome, hearing, of course, this is the day of Jimmy Carter's funeral. He started addressing the guinea worm in Ghana in 1988. And it took 36 years for them to eradicate that. And this was someone who was a former president, who had all the resources of the federal government and all the resources of the nonprofit world working with him to eradicate that. And that was 36 years for one disease. And so you could imagine, it's not bells and whistles for us, but you can imagine the work and the resources we need to eradicate and to deal with health equities and disparities. And so just wanted to put that thought out there. Someone who's had all the resources in the world and all the information they need, such as our former president, the time and the effort it took to eradicate that. Imagine what that will do for our communities, if we had those resources.
Okay, Anthony.
Yeah, thank you. So I guess I'll address the latter question that you asked, Jerome, and then I'll come back to the original question. In terms of folks creating systems of care that didn't exist before, one example that comes to mind right away for me is during the civil rights era. There were a lot of Black and Brown communities that created healthcare systems community health centers specifically that didn't exist for them at the time. The history of the healthcare system in a nutshell is that it's always been it was created for protecting the capitalist class. It was created to protect capitalist interests. It's always been for the wealthy. Black and brown folks weren't part of that equation from the get-go. And so during that period of time, that's when these communities really had to create these systems for themselves. And as an extension of some of my own work, I've seen there's one space in Houston, Texas that comes to mind that they're undocumented immigrants that are all disabled that have created a health system for themselves because they've been locked out of every other formal system, right? And so that creativity is there, that mutual aid network, these mutual aid networks exist and are going to become more and more important throughout time, which takes me to your original question, Jerome, about why we haven't seen the needle move. And I think I'm just echoing really what a lot of folks have already said, but I do think one of the biggest reasons is because we are still stuck on this capitalist logic of healthcare, right? That is very for profit, that is very much about maximizing the bottom line, where the community is seen as the safety net, if it exists at all, right? And so what we need to do to advocate for health equity, health justice is focus on the community health, right? Because if we have what we have right now is a healthcare system that is very for profit, very capitalist, and beneath that, if you will, are people caring for people within the realm of community healthcare. If we eradicate the healthcare system, what we're left with is actually people helping people. And that's what we need, I think. I think all of this is to say that really what we came into with this panel, right, is this, what we want to see are calls to action. And if there's one thing that I would sort of emphasize as I'm closing my comments here, is that it's okay to be upset, that it's important to be, right, with how the healthcare system is operating right now. And so I think one clear call to action is to continue to call for change, right? I think we continue to do that. Our voices are loud and we need them to be heard.
Excellent, excellent. We have time for one more question, and there is one, and it's related to these systems of care. I'll read it just as it comes across. How is culture defined by predominantly white institutions in relation to the diverse populations they're serving? Are those populations defining what culture is to them? And specifically, what type of culture is being cultivated between Western mental health professionals and people of African descent? Now, that's a powerful question, and I think, alludes to, Anthony, what you were saying just now in terms of what could be considered mainstream, trying to, quote unquote, take care of people who are not, and this word culture that we all use, but that is embedded in healthcare systems, again, and someone said earlier, not designed to take care of the very people experiencing the health disparities. So I'll read it again and have any one of you respond. How is culture defined by predominantly white institutions in relation to the diverse populations that they're serving? That is the crust of the question.
I'll say this, Jerome, I think the answers in the question is who's framing the conversation. If it's a white institution or an institution that does not have diversity in the conversation, then that framing of the nomenclature is by someone who doesn't understand the culture. And so, yeah, I think that's why a lot of us are here theoretically in these roles, is to be that voice in the room and to be that cultural presence. But then again, who's framing the question and the network, and who's framing the strategies? Back to Dr. Jimenez's point, that's the problem. Are we in the rooms? And then once we're in the rooms, even if we frame the questions and the strategies, are we given the dollars to do it?
Yeah, I'll add to that. I think it is hard to frame culture that you don't understand, that you don't connect with, that you're not a part of. So representation at the highest levels of leadership, we spend a lot of time talking about job, workforce development at the lowest level, but there shouldn't be many institutions in our community that are sitting with 100% of, a certain type of race. I mean, we serve a diverse community. And if what I find amazing is that when we are at the table, we are capable because we are community. We are capable of bringing those voices forward. But unfortunately, I agree with you. If you don't have the power, the influence, or you're not at the table or have the resources, it really gets lost. So for me, it's encouraging. My call to action is go back, look at your board. Is your board representative of who you're serving? Is your executive leadership team representing of who you say you're serving? And if it's not, I mean, that's a great place to start. You can fix that. You have power over that. When the Biden administration was running, Unidos US did a campaign that said 20%. 20% of all his cabinet should have looked like Hispanics, because that's who this country is, 20%. So just even applying simple concepts like that, looking at your population and saying, do I represent that, is really, really important.
I just want to add, because we talk about being at the table and representation, there's a term that's coined, glass cliff. And so the glass ceiling cliff. And so that's important, because when we are at these tables, let us be able to do why you want us at these tables. If it's consistently those barriers there, then we're not going to be able to do it. And you're going to continue to see the black flea of these institutions. Trying to keep myself together because I in my position, but if we don't have that support, then you're going to see the glass cliff, and you're going to see a lot of us saying we're going to do our own thing and continue to support our communities.
Unfortunately, and I knew this was going to happen, and the this being, because now we get into the get, right? This part of the conversation is really, really powerful. And when I look at the screen, not only who is on it, but the institutions that they represent. We have both. Institutionally, in terms of the healthcare system, we have our two largest healthcare systems represented in Dr. Williams and Lonnie. We have government represented with respect to Monroe County and Dr. Aycock and the heavy, heavy lift that she has. We have our community healthcare system represented in Jordan Health via Gary, our moderator. We have RIT represented in Dr. Jimenez. And I call her my partner in good, Angie and myself, in terms of the not-for-profit world and the other organizations that, you know, we have a little crew in the Urban League and the YWCA and the Healthy Baby Network. You know, we talk a lot about this. And I think it was Dr. Jimenez who says, continue to advocate, right? Continue to advocate and focus on community health. We're certainly going to do that. And this is just a snippet of that. And so I want to thank all of you for giving of your time. Masterful job, Gary, as moderator, you know, moderating this Power Pack team that, you know, sometimes they stay in time, sometimes they don't, but they have a lot to say, and we understand that. There was one other question, and particularly for you, Lonnie, and Dr. Williams. Someone was asking about volunteer opportunities at both of the healthcare systems, and you know, you can certainly send that to me, and we can push it out to everybody because, you know, we have to show up in these places and be intellectually vocal. So once again, I'm grateful on behalf of ABC and our staff and our board. Thank you for your contribution to what has been an amazing afternoon so far.